Hey, this is Kendrick with worldmedicalschool.org. We're going to talk about penetrating trauma or penetrating injury. This was kind of a tough topic to put together just because I had to go through the different areas and pull out the most important parts, or what I thought were the most important parts. I also used review materials to help pick out what was the best parts to include here. So let's start with the neck. Generally, you think of any wound that violates the platysma as being a penetrating neck injury. We break the neck up into 3 zones. Zone 1 starts at the sternal notch and goes up to the cricothyroid cartilage. Zone 2 up from there to the angle of the mandible, and Zone 3 from there up to the base of the skull. So these zones help us to think about what anatomy is in there. Also gives us some prognostic factors because Zone 1 is associated with the highest amount of mortality. Some recommend that you do mandatory immediate exploratory surgery if your wound is in Zone 1 or Zone 2, but most people say that is just depends on the situation. So for diagnostic tests, you do CT with or without angiography. You can do Doppler, contrast esophography, esophagoscopy, or bronchoscopy can all be used to help determine where your injuries are. Generally, it's easier to find arterial injuries than it is venous or esophageal injuries, so you want to make sure that those are ruled out. For treatment, you want to make sure you intubate early, and especially if you have hemoptysis or a stridor or hoarseness or any other indication that you have real penetration, then get stable airway in and prepare for a surgical airway before you intubate, because you may have a failed intubation and you need an immediate surgical airway. Also, with intubation, you can end up, in some cases, causing an incomplete laceration to become complete, or you can rupture a vessel or something. Anyway, be sure to use direct visualization when you intubate. Sorry, that was a lot of words to just say. Use direct visualization. So indications for immediate exploratory surgery include shock and ongoing hemorrhage. And for chest, we're going to go over pneumothorax and hemothorax in a little bit more detail in our primary trauma survey, which we'll probably do next. But for chest penetration, you want to think about these: pneumothorax, hemothorax, flail chest. Also think about hemopericardium. And a thoracotomy is going to be important in several of those. And if you're not sure about what type of a chest injury you have, if you're not sure if you have pneumothorax or hemothorax, you may want to do an empiric chest tube. And another reason to do this is because if you intubate before a chest tube in any of these injuries, you might lead to cardiopulmonary collapse. So chest tubes first in a lot of these cases. Trauma that leads to cardiac arrest is an indication for a thoracotomy, at least if the arrest was in the ED or just before arrival. With chest penetration, or really any of these, if you have an impaled object, then leave it in place, because it may be tamponading the wound, so it might be keeping you from losing too much blood. So leave it in place until you go to surgery. If you have a patient that is previously stable and then suddenly dies, think about an air embolism. If you have a new diastolic murmur, think about aortic dissection. For abdominal injury, a CT scan and FAST scan are helpful. FAST scan has debated utility in demonstrating hemoperitoneum, but it's definitely still used. Diagnostic peritoneal lavage is what we used to use a lot of. and I guess we still do. I don't know how much it's still used, but that just means that we aspirate any fluid from the peritoneum, and we also will put in a liter of fluid, let it sit for a few minutes, and then pull it out again and send it to the lab to help us figure out what kind of damage we have inside. And immediate exploratory laparotomy is indicated for anybody who's unstable, for peritoneal signs, for evisceration, which just means your insides are on your outside, or if you have an implement in situ. A lot of people will consider that an indication as well. So if you have a knife sticking out of your belly, then you get to go to exploratory laparotomy. For musculoskeletal, some of the big things to think about are just whether or not we have nerve or arterial damage. Of course, that's true of the others as well, but with this we can check for sensory and motor function. We can check pulses. As far as decreasing infection is concerned, we want to do early wound irrigation and tissue debridement, which will be more important even than the antibiotics, which of course we're going to do anyway, and make sure that we get any foreign bodies out. Tetanus prophylaxis applies to all the other areas as well, and we just often think about it with sticking on a nail or something, stepping on a nail, but it applies to all these. So if you have had less than 3 doses of tetanus vaccine and it's a clean wound or just a smaller wound, then you do give the vaccine. You don't give the tetanus IG. If it's a dirty or a major wound and you have less than 3 doses, that's the only circumstance where you give both the vaccine and the tetanus IG. So a big or a dirty wound and you've had less than 3 doses of vaccine, that's when you give tetanus IG. If you've had greater than 3 doses and it's a small, clean wound, then you give the vaccine only if it's been more than 10 years or you're not sure. And if it's a dirty or a major wound, you give it if you've had the vaccine greater than 5 years ago or if you're not sure. So in review, don't pull objects out because they might help stop bleeding. You get tetanus status for everybody and they get the appropriate prophylaxis. And you intubate early especially in chest and neck wounds. Thanks to our human male body picture from the public domain, and if you want to get involved or help with the project, you can comment on our videos and tell us how to make them better, or you can volunteer at worldmedicalschool.org/volunteer.